start by just saying that it's indeed an honor and a pleasure to have been selected to be this year's Libby Harricks Memorial Orator. It's also, I'm very pleased to have been invited to attend this inaugural event of the launch of the Australian Hearing Hub. Special thanks to the Deafness Forum of Australia and Dr. Ginny Rosen for inviting me. I'd also like to thank Professor Janet Greeley and Dr. Harvey Dillon for inviting me to attend and participate in the Australia Hearing Hub Conference. And I'd like to thank Professor Catherine Demuth for hosting me this week. And I didn't realize Cochlear had such an important role in this, so I'm sorry you're off the slide, but I'd like to thank Cochlear Limited. Okay. And in this presentation, we are honoring the memory of Libby Harricks. But I don't think Libby will mind, but she's going to have to share this spot also with Dr. William House, who we recently lost in December, the father of neuro-otology and my first boss. So many people have asked me, have I ever been to Australia? And in fact, I've been here twice. And the first time was in 1979. I came with two colleagues from House for an otolaryngology conference. We were presenting some results on the single-channel cochlear implant in adults. We had not yet started children. And I don't know if you recognize some of these people, but here we were in the rocks, at the rocks, when NAL, do any of you remember NAL being at the rocks, in the rocks? Yeah. And does anybody recognize Doug Fifield? Yeah. And who's this guy? Yeah. So we had a wonderful time with the NAL group. And NAL suggested we stay in this area called King's Cross. And it was really colorful. But can you hear me okay? But I want to say that this establishment called Harry's Café de Wills was really interesting to me when I looked at this photo, because that was 1979. Now in Los Angeles, the food trucks are the biggest trend, and they drive all over the city, and they will send out tweets where they're going to be, and people will drive all over the city to follow these trucks. Okay. The second time I was here was, I believe, in 1983 or 1984, I can't really remember, and this was really odd. The nucleus device was already, had been launched in Australia and had started to move into the United States. And I don't really know how this happened, but the 3M company that was marketing the single-channel device thought, oh, maybe we can get our foot in the door in Australia. So they had this conference, and they brought some of us over, and we had already started our children's program. I don't believe the nucleus device had been tried in children yet. You'll have to correct me. Not quite yet in Australia in children. So it was a little odd coming to Australia thinking we could come in with a single channel device. I mean, it was just a little odd, a little intimidating. And at this point, I do want to acknowledge Professor Graham Clark. He's the 2009 Libby Harricks Memorial Orator. And he spearheaded the first development of the multi-channel device known as the nucleus device. And Professor Clark and Dr. House and some of those other early clinical pioneers, took a big beating in those days. It was very unpopular to think about putting an electrode in deaf human subjects, patients. There was a lot of animosity about it, and I've been hearing stories that not only did Dr. House take a beating, but also Professor Clark did as well. And it was particularly the basic scientists that were appalled that clinicians would go ahead without the proper long-term studies. And it was quite a fight. I mean, even our National Institutes of Health got involved with this argument. They put out a contract, and we were told by the principal investigator, they were told, we want you to stop this now. That's the goal of your research. True story. But I can say now, looking back, instead of saying it was a big fight, we can just say there were opposing philosophies. And I think it's important to see what the differences were between the basic scientist and the clinical researcher or the clinical scientist. So the basic scientists felt there should be an emphasis on the science with animals, use of an animal model, and long-term studies with animal models. The clinician felt the emphasis should be on clinical research with humans. These were physicians who had patients who were deaf, either adventitiously or congenitally deaf, coming into their office, and they were told, the patients were told, there's nothing we can do for you. And the clinical surgeons found this is our opportunity to help this population. Another opposing philosophy is that cochlear implant performance was evaluated in the context of normal hearing. And the early results coming out with not only the single-channel device, but I think the first device with the nucleus, multi-channel device, was a pitch extractor, a speech extractor, and it extracted the FO, fundamental frequency, and second format. And let's face it, that was a pretty crude device too. So results with those first very early devices were a little underwhelming, and the basic scientists, just thought that it should be shelved. But the clinicians, and I think almost every one of you in this room would agree that the CI performance should be evaluated in the context of deafness, not in the context of normal hearing. So for somebody my first patients that I worked with were adults who were deafened after having developed language. And, being able to hear again was a big deal. It was really a big deal, even if the sound sounded like Donald Duck when they first were stimulated. So I often have recollections about children with single-channel implants. This trial began in 1980 when Dr. House implanted the first child. He was a 10-year-old, almost 11-year-old congenitally deaf child who spoke sign language, not signed English, but Amazigh, which was a different language than English. And, that was the beginning of our trials. And I've often thought, looking back, were the children in that first trial, were they born too early or were they implanted too late? Born too early, they were implanted with the very first devices, whether it was the single channel or the very first multi-channel devices. Implanted too late, we found that the average age of children to have received the single channel implant in that first clinical trial, the average age was 8 at implantation. That's quite a late age by today's standards, and we know a lot more now. So what's happened with those children? Nobody has really done an investigation, but this is my observations from being in contact with some who will come back to the House Ear Institute. Some of those single-channel children did, in fact, attain open set recognition and develop spoken language. These tended to be children who were in very strong auditory programs, had very strong family commitments. Many of those children went on to upgrade to multi-channel systems, graduate from college. But when I meet these adults now, they sound very deaf, they have very deaf speech. Many of them are not intelligible, but in fact, they are probably identified or labeled as being deaf, even though they've had this implant since early childhood. so implanted too early. Too early. By far the majority probably stopped using the device altogether. Most have been lost to follow-up, and most are firmly entrenched in the deaf community today. So this gives a little introduction, and I'm going to come back to this as we get near the end of this oration. But as an introduction, I'm now going to focus on what I would like to speak about today, and that is, from where have we come, even before single-channel implants and early multi-channel implants? Where are we today? How are we doing? And what are our remaining challenges and new directions? So, from where have we come? And I'm going to frame this in the context of deafness, as the early clinical researchers did. Okay. Then, this was before 1980, probably before 1970 and 60. Children were identified with severe to profound hearing loss at older ages. The research tells us with a profound loss, they would have been identified at about 1 to 2 years because parents recognized something was wrong. The pediatricians certainly didn't take it too seriously, but the parents often noticed, especially if they had other children. And noticed these children were not developing and communicating in a similar way to their other children. Young children with more residual hearing, in fact, could have been identified at 3, 4, and 5 years of age. Add another year for fitting hearing aids. Long delay, and we know a lot now that those early years are essential. Deaf children were often referred to specialized schools, state-run schools, or private schools. Many of them were focused on train the children on sign language. That was their communication. And then there were some schools like CID, Clark School, that focused on teaching children to communicate orally. Hearing aids may or may not have been used with this pediatric population, depending on the program they were in, and auditory training may or may not have been instituted, and that goes for speech-language therapy as well. So how were those children doing in communication? I'm going to break this down into speech perception, speech production, language, and literacy. This is just sort of a brief bullets that captures what we knew in those days. I'm a little more detailed in the monograph that you receive. So, what speech features were perceived by children with hearing loss? This was a question that Arthur Boothroyd wanted to know, and the study he published in 1984 in JSLHR today remains a classic. So he wanted to know what deaf teenagers at the Clark School were perceiving as a function of hearing loss. We really didn't know this in this population. So these are some findings from this 1984 paper. If you actually find the paper, you will not see this figure. This figure has been adapted from a 1985 publication in which Boothroyd interpolated and extrapolated the data from the original paper to come up with children with a moderate loss, severe loss, and the different degrees of profound loss. So what you're seeing here are the different features of speech. The most difficult, these are ordered by difficulty, consonant place, to the easiest vowel height. You will see some suprasegmental tasks, listening tasks, temporal pattern, talk or gender. But the rest really have to do with speech feature or speech pattern contrast. And you'll see if we look at the children with moderate hearing loss, they really have access to all of these cues, consonant place, all the way to vowel height. Once we start getting into the severe range of hearing loss, we start to see consonant place break down, and that is indeed the most susceptible feature for hearing loss. We get into a profound, and here you see we didn't even realize there was this much information that patients with profound loss could have. Look, somebody with 90 to 100 dB hearing loss had access to quite a few features, although this was probably below chance here. And then we get down to 120, 30, which I suspect is vibrotactile information. They still had access to vowel height. These were very interesting findings, and I don't know if it's your experience, but when we first started our implant program with adults, we required them to be fitted with high-powered hearing aids, be trained for 6 months, and then a decision was made. There weren't tests because we didn't have tests to test these adults. So we had to actually see how they performed in therapy tasks to determine were they getting anything from this hearing aid. A very interesting consequence is a number of these patients found they were getting something from these hearing aids. No audiologist had fitted them before. And these patients said, no, I don't want an implant. I want to wear a hearing aid. So we were starting to fit individuals with hearing aids that we typically wouldn't have fit in the past in those days. Boy, times are different, aren't they? Okay. So now we'll move to speech production, and we know there's a correspondence between perception and production. So we find with those who were deaf or with profound hearing loss, articulation would have been delayed and in most cases absent. A lot had to do with what school program they were in, what philosophy of communication. Intelligibility was related to the extent of residual hearing, but most were unintelligible. And in a very classic study by Clarissa Smith in the mid-70s, the mean rating for speech intelligibility of deaf individuals was 19%. And I think most people are familiar with the speech characteristics of deaf individuals without hearing aids or with cochlear implants. Those that did speak were in oral programs. Their voice quality was often marked with breathiness, wide pitch excursions, and abnormal nasalization. Okay. Language, here, acquisition of language is not exclusively an auditory-based skill. We know that a child with absolutely no hearing in a sign language program can learn to have very good language, age-equivalent language. It's just not spoken language. So there is this disconnect, and a little piece of history when they started the first clinical trials with cochlear implants, submitting these devices for an FDA study. The manufacturers never put language in as one of their claims. They didn't really put speech production, as I recall. It was mainly auditory detection and speech discrimination and some recognition. So what did we know about language? We know that although the majority of deaf children communicated through sign language, some did develop spoken language. We've already sort of alluded to this. But again, this was based on the amount of residual hearing. Typically, though, children who were learning spoken language had to be trained through face-to-face communication rather than the way children who are hearing learn, and that's through incidental learning. And in fact, spoken language would be delayed or disordered throughout the lifespan. Literacy, and I just have one little bullet point. The classic finding, reading did not exceed a 3rd or 4th grade level. So where are we today? Well, a lot of wonderful things happened in the second half of the 20th century. First of all, we had early identification, and not just, those children at high risk and those children in the neonatal intensive care units, but it expanded to universal newborn hearing screening. They now call it in our country early hearing detection and intervention, or EDI. And a lot of this had to do with these findings of the 1998 paper of Yoshinagi, Tano, and colleagues, where they found that children identified and fitted in starting intervention before 6 months of age acquired much better language skills. Didn't have to be spoken language, even with sign language. They acquired much better language skills with early identification and intervention. Innovations of the last half of the last century, not only was the multi-channel cochlear implant innovated during that time, digital hearing aids. And digital hearing aids have had a very big impact When I was an audiologist, we weren't even allowed to dispense hearing aids. You would be kicked out of your organization. You would lose your license or your certification. And an audiologist could write a prescription, but then they would have to send it to a hearing aid dispenser. But, now audiologists can adjust that hearing aid right there in the clinic. And another important innovation were the public laws that enable the child to be educated in the least restrictive environment. And I'd also add that that state and federal funding became available to help those families that needed support. So now what do we know about speech perception? Well, I like to start with new test development because, as I said earlier, we didn't even have tests to test patients. Patients who'd be tested on the standard SRTs and speech word recognition tests in the clinic would be at floor. And I think that's one reason Arthur Boothroyd actually, with his AB word lists, scored by phonemes correct, because if you may not get the full word, but you may get a vowel correct, you may get a consonant correct. So starting with new test development, I have to give credit to Norm Erber. He really is the unsung hero in this area. He was the pioneer, and two tests, he developed more than two tests, but two tests that had quite an impact on our discipline was one, the MTS test, which stood for monosyllable trochee-spondee test. Dr. Erber called it the monster test, but in the States we called it MTS, and it became part of the clinical battery in investigating cochlear implant efficacy under FDA trials with adults. The GASP test is the Glendonald Auditory Screening Procedure, and it's a word test and a sentence test, and it's interesting questions. You don't ask a child to imitate the sentence. You ask the child to actually answer the question. How many legs does an elephant have? If they say 4, then they're comprehending that information. Our audiologists still do the GASP test today. And now I'm going to move on to a test that is a staple now in our clinic, our pediatric cochlear implant clinics, and that's the early speech perception test developed by Gears and Moog. And would you say that evolved from Norm Erber's original MTS test? They took the MTS test but broke it down for much younger children. And another innovation that evolved out of the technology of cochlear implants were open set tests. You've already heard about the LNT test, and spoke about that this morning, the lexical neighborhood test. But there were two tests, the multi-syllabic lexical neighborhood test. And these tests were different from many other tests that have been developed for the audiology clinic because they were theoretically motivated. They were based on Luce and Pizzoni's neighborhood activation model. And these also are generally tested in the clinic in most research protocols today. So I'm going to now move on and sort of talk about what results we're seeing. And we have a large sample of children in a study going on in the United States. It's called the CDACI study, or Childhood Development After Cochlear Implantation. John Naparco is the PI on this grant. There are 6 centers that enrolled patients starting between 2002 and 2004, and we have continued to follow those patients. We're now in the 11th year of the study. There were 188 children with implants and 97 normal hearing controls. And I'm going to show you the approach that we have taken in this study using a battery approach, but also a hierarchical approach. So you'll see the battery has some of these tests I've just spoken about, the ESP test, the MLNT-LNT test. But we've chosen this hierarchical approach where we start with auditory behaviors, which are really this ITMACE or MACE, which is Meaningful Auditory Integration Scale. The IT stands for infant toddler. Are ratings that parents respond to because very young children, you often can't test them, but this gives us information even pre-implant, how children are doing generally with their hearing aids and then after they get an implant. But with implants, children top out pretty fast on these measures. Now, by the time a child is 2 to 3, many of them are able to start taking the early speech perception test. And then by the time they're 3 to 4, we've instituted Susan Jerger's pediatric speech intelligibility test, which is a picture-pointing task of words and sentences tested in quiet and in background competition with a single talker. And then for those children who reach the age of 5 and older, we have the tests, 4 to 5, the MLNT, LNT, as we've said, and PBK, which are standard tests, phonetically balanced kindergarten words, and hearing and noise test for children. Now, children aren't tested on all of these. It's a hierarchy, so they have to meet criterion on the earlier test to progress to the more difficult test. Now, there's some advantages to this. First of all, you're not going to have floor effects, and you're not going to have fatigue of a child, having to come to the clinic and being tested on 1, 2, 3, 4, 5, 6, 7, 8 tests. You're going to have to test a child in the region where he has some perception. So if a child has met criterion and gone into past pattern perception, but into closed set word identification, we would move them into the pediatric speech intelligibility test. They have to be of a certain age and a certain ability to move on to these tests. The disadvantage with this is, you can imagine, how do you present your results? If you only have a certain segment of your population being tested on one test, it's not really clear. You're not testing the children where it's too hard or the children where it's too easy. So the biostatistician on the CDACI came up with this technique called the Speech Recognition Index. And what he did was stack. Under the assumption that this hierarchy really did go from very simple to much more complex or difficult tasks, that he stacked them and gave them a value, a percent value. And if a child came in at a certain test interval, maybe they were tested on the PSI sentences, but then the audiologist said, wow, they did really well, they meet criterion, I'm going to move them up to MLNT. If that's where they stop for that interval, just the MLNT test becomes a data point. And you can see the scores range from 0 to basically no detection to 600, which means hearing and noise test, sentence score, just testing sentences. All of these are in quiet. We haven't developed any further with the tests that have background competition. So I'm going to show you the 5-year results on this now, and I'm going to walk you through this. This is a scatter of all the data of children who were tested from baseline at 0, pre-cochlear implant, all the way to 5 years. These are median data, and they turn into percentiles. This solid line is the median of the data. It's the 50 percentile. This top line here represents the 90th percentile, the top 10% of the sample, the 75th percentile, the 25th percentile, and the 10th percentile. And what you'll notice is that, like most things in pediatric cochlear implantation, there's wide variability, and we see that here. An interesting thing, there's a lot of things you can glean from this. For example, this 300 boundary is an important boundary because it's the crossing over from closed set to open set word recognition. So what's sort of exciting, I think, is you can see this top 10% group. They were achieving or crossing this boundary within 1 year of getting their implant. And these are young children. They were implanted anywhere up to 5. Some were implanted under 12 months, but the average age was 2 years for this sample at enrollment in the study. So then you move to the 75th percentile of the sample, the top 25%, and a little after a year and a half, they're crossing into open set. The average would be, or the median would be at about 2.5 years. Oh, here we go. And the 25th percentile crosses over at about 3.5 years. So this is basically saying that 75% of children with a cochlear implant will be getting open set speech recognition. And that's a pretty great finding. But now we look at our 10th percentile group. Even after 5 years, they are still in basically some not more than detection, some in pattern perception, but not going into even closed set word identification of the PSI. Why is there a group of 10% who in this sample are not progressing with the implant? Well, we're in the process, we're hoping to look at that in much more in-depth, but in more detail, but I can tell you that some of these children, after being implanted, started showing signs of autism. Some of these children, even though we had an inclusion criteria, started having delays. And some of these children, I am convinced, did not have an auditory nerve or enough of a nerve to really make use of a cochlear implant. Some of these children, if we'd had better imaging during those days, most kids had CAT scans, but today they're trying to have children be imaged by MRI, where you get much better resolution of the auditory nerve. Some of those children, had they had an ABI, may be doing a little better. And I'm going to actually show you the results of one child we've been tracking. I can tell you that we have just received FDA approval to do the nucleus device in the United States on children. But there have been children who've left the United States and gone to Italy to have the procedure because the FDA would not grant it. Since we've been working on this for 7 years. So here's one child that we've been following for 4 years with the implant, and we are using the CDACI speech recognition battery. And you can see at year 1 out to year 4. We'll be seeing him in June for his 5th year. So if a child who didn't have an auditory nerve probably is down around here, this child with an ABI, you can see in closed set, was performing very similarly to the median or the 50th percentile of the sample. This child did cross the boundary into open set and now is firmly in open set. He's now looking a little bit more like the 25th percentile of the sample. But that's a far cry, and there's a lot of potential for children who are good candidates, who see a very skilled surgeon, have strong parental commitment to this, and have programs set up in place to actually provide auditory input and therapy for auditory training. So I think this is an exciting new future event that's going to be happening very soon. It's not a large population, but hopefully we will have less of these 10%ers for those children eligible for an ABI. Okay. So we talked about tests being developed because once implants came, we needed new tests to track these children. But also with newborn hearing screening, we needed tests to evaluate infants and toddlers. And so there has been development in that area. I think the first one was by Pam Dawson from Australia, who developed the speech feature test. This actually was an impetus for us for some of our test development. Gevertz developed a test called the Auditory Speech Sound Evaluation. And Boothroyd and our team at House Research Institute developed a battery of tests on speech pattern contrast called VRA-SPAC, Olm-SPAC. VRA-SPAC, as you can imagine, is similar to visual reinforcement audiometry, but instead of trying to determine detection or threshold, we're now looking, can a child detect a change in a speech contrast? I'm going to show you an example. This is the setup for this VRA-SPAC. The child would sit in the parent's lap. Sounds would be delivered, and I'll show you the stimuli in just a sec. The child would be trained to respond and reinforced for hearing a detecting a change between two syllables. And then the child would be rewarded, and then we would institute testing. I will tell you we use an interesting paradigm because some of the tests that are on the market and available require you to have like 20 tokens, and the child has to perceive correctly 17 tokens correctly. And most infants don't fatigue before you get there. So the genius of Arthur Boothroyd, excuse me, was to develop an algorithm based on probability theory, where the child would turn their head within a certain time window from the time the contrast is instituted. So if you have, for example, udu, 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 ed, 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 when it turns to ed, the clock is ticking and the child has to turn their head within a hypothetical window that is determined by the tester. It also takes into account false positives. If an infant has no false positives and turns within a hypothetical window, which indicates that the head turn probably was not random, the test might end after 3 trials and you can move on to the next contrast. This increased the efficiency of testing these infants with hearing loss. I'm going to show you, these are the stimuli. We test vowel height and place, and then consonant voicing manner, and then also consonant place with the front articulators and the rear articulators. And here you have examples. Right now, the algorithm has vowel consonant vowel stimuli. My preference would be to move to a simpler stimulus, such as vowels in isolation or consonant vowels. But this is just showing an example on 4 infants with different degrees of hearing loss. Because of the probability algorithm, they almost have to get it perfectly to give us a certainty or probability that it was not just a random head turn. And you can see, similar to Boothroyd's results of 1984, here are results on children with mild hearing loss, moderate, severe, and profound. It's 4 infants all wearing hearing aids. And you can see the child with mild hearing loss and moderate essentially have access to all but maybe one of contrasts. One was consonant voicing, one continuance or manner. Once we get to a severe loss, they have access to the 2 vowel contrasts and probably the consonant or manner, continuance or manner. And at 115 dB, the child only had access to vowel height. I find these very interesting because these are early identified infants fitted with hearing aids very soon, and the results really don't look very different from Boothroyd's data with deaf teenagers or hearing-impaired teenagers from the Clark School during the 70s and 80s when he collected his data. So speech production. And I'm an audiologist, so you're going to see a lot more on speech perception than the other domains. We're going to talk a little bit about articulation and intelligibility. So here you can see some of the authors of studies that I sort of summarized and gleaned this information. With a cochlear implant, a very interesting finding that they're able to see babbling emerging within 1 to 6 months after activation with the implant. You don't see that with typically developing infants. It usually takes a little bit longer than age 6 months, especially to see canonical babbling. But articulation errors persist. There are children that don't develop completely normal, articulation-free, error-free articulation. Intelligibility, and I'm sorry, your results were much more impressive than the results I gleaned from the literature. But when you look at a sort of a compilation of studies, I think I got this 70% perhaps from, can't remember, I'm sorry. But not all children are intelligible. That's part of the wide variability in this population. Spoken language. Okay, again, these are the authors of some of the important studies, I think, on language development. And we know that children with cochlear implants definitely outperform their peers with profound hearing loss using either a high-powered hearing aid or a vibrotactile device. This was one of the first studies Moog and Gears did at the very early part of this new technology. And Anne and I were talking about this at lunches. They thought the kids would do the same with a vibrotactile device, but they didn't, did they, Anne? Another study, the Indiana People Group with Mary Jo Osberger, came up with comparing children with what they called, within the profound range, bronze, silver, gold. So the children who were considered bronze were at the very bottom of the audiogram. Children who were gold hearing aid, gold users were at 90 to 100 dB. And they were able to then compare where a child with a cochlear implant did in comparison to those different ranges within profound hearing loss. Today, our studies are all compared with children with normal hearing. And we know earlier is better. There's no doubt about it. And, of course, wide variability. You see a pattern. Okay, these are just some studies from John Naparko's 3-year language results that appeared in the Journal of the American Medical Association. Comprehension scores, expression scores on the Renell. And the black line and the dot are the normal hearing controls. And at the 50% point or average, they were at this score about a year and a half. And then we could compare children with cochlear implants by degree of hearing loss. Those implanted under 18 months, those implanted between 18 and 36 months, and those implanted after 36 months. And you see earlier is better. It's not quite as steep a trajectory, but it's certainly steeper than the later ages at implantation. We also see this with expressive language. One of the findings that this study showed is the factors that contribute to how well you do with spoken language in a cochlear implant. Obviously, age was an important factor. It was a predictor. Socioeconomic status was a big predictor. Parent-child interaction. And there was one more, pre-implant residual hearing also contributed to who was going to have better language scores. Now, these are not like the scores we saw this morning. And this study has a very wide variability. It's at 6 centers around the United States. We have a wide range in socioeconomic status. These children were selected consecutively, not handpicked. So if you were a center, every child who came in once this study commenced, if they met the original criterion, they were asked to enroll in the study. There was no cherry picking. But it's interesting that these children don't do as well as we're seeing in some studies. And part of it is they were enrolled anytime up to age 5. Well, that's quite a late range now by today's standards. And there were some children implanted under the age of 12 months. And even though the study was not powered to test this, Toby just published a paper on the 6-year data of the CDACI study and did segment out children by age, and the children implanted under 12 months did in fact have better scores. Okay. And literacy, phonological awareness, and reading. Okay. So looking at these 3 studies, we found that lags were evident on phonological awareness tests. Ambrose just published a paper on children, preschool-age children tested on phonological awareness. I think on average, they were within the standardized normal range, but they were at the low end, and they were statistically significant lower than the normal controls. Reading skills definitely now exceed a 4th grade level, and many children are reading on par with their hearing peers. So the cochlear implant is an evolving technology, as Anne showed this morning. I feel like I'm giving your talk, Anne, all over again. And as implants become more technologically sophisticated, results do get better. Younger children, more residual hearing. And yet, even with knowing all of this, there are challenges that remain. Okay. The wide variability in outcomes. A lot of studies will show you the stepwise regression and the R-squared results for a number of predictor variables. And while several predictor variables do contribute to a lot of the variance in the data, there's still unexplained variance. Changing demographics. All major metropolitan cities are confronted with changing demographics. I know in Los Angeles, in the Los Angeles city schools, the majority population is Latino, but we have a lot of children immigrating from a number of different countries and many different languages. And we confront the problem, at least in our center, and I'm sure your centers too, that what do you do when the family does not speak English, but they will be educated in an English-speaking school? It's important. Our philosophy is sort of evolving in this, and our feeling is that children need a good language model, especially if they're implanted very early, and most of their input will be in the home. So they will learn English. Once they start playing with other children, going into public schools, they will. But the home language, the birth language, is important for modeling for those children. Increasing poverty, low socioeconomic status. In our country, the middle class is being squeezed, and we're seeing much larger growth in the lower classes. And with that comes widening health disparities. We know this from the Risley Heart studies, 30 million words that children of working class families tend to develop words and acquire words at a much less than children of professionals and middle class families. We also know the role of the family is very important, that limited parental involvement will contribute to the widening disparities in families of low SES or socioeconomic status. And there is a pressing need, almost a critical need, to intervene early by developing specialized parent-child training programs. But the good news is that there are programs starting to be developed specifically for these families. And I'm going to give a plug for Dana Susskind from the University of Chicago. She's a pediatric otolaryngologist, AKA social worker. And this actually is her real love. And so she has, with some grant funding, been developing two projects, one called 30 Million Words and one called Project Aspire. Project Aspire was directly being developed for the children she sees in her practice who are of minority status and low SES. And she felt she had to do something. She's starting to be presenting. I think she's presenting at an A.G. Bell meeting coming up. Our center deals 70% of our population in our clinic, our pediatric clinic, is on public assistance. By far the majority of the children we see are from Hispanic families, and we're seeing a discrepancy in children between really, because many of them go to John Tracy Clinic, but once they're getting past a certain age and getting ready to go into elementary school, they're not ready. They're not ready. They don't have the skills, and especially they're not ready to learn to read. So we're developing a program, Read to Succeed, as a summer program to work with families, low SES, not English speakers, and to work with their families. So I think this is going to be a pressing problem. I think there's a great need to develop tools and programs in this area. And maybe we'll reduce some of that variability. And even more good news, I'm very impressed by the LENA system, the Language Environment Analysis. We don't happen to have one, but I'm starting to read the papers that are coming out. They're just starting to come out in children with hearing loss. But it's, if we're moving in the direction of families, we can see how the family interacts with the child, and from there we can have intervention. And it has some great potential for research. We spoke about this, Professor Demuth and I were talking about it, and she said she didn't feel that there was enough resolution to really get in and see what's going on. But I bet researchers could contact the LENA Foundation and say, we have a project, would you be willing to help us glean those data, have a different kind of program? I think that would be important too, because I think this will be a really nice tool. And new directions. For me, I think the new area, based on what I've just spoken about, is the role of the family and the home environment on language and literacy. I'm going to talk primarily on the parental role, the maternal contributions to language and literacy, but I will just give a plug for Rachel Holt, David Pizzoni, and Bill Cronenberger from Indiana University. They've recently published a paper on the family environment scale and are starting to actually go into the home to evaluate that environment. But moving on to language and literacy, I'm going to discuss two studies by Jean Desjardins on maternal contributions. One was specifically on language. These are both studies on children with cochlear implants. One study was to look at the maternal contributions to the child's language development. Then there was a follow-up study to look at as many of these early children she tested and see what the early scores, how they impacted later literacy. Okay. So in the language study, she asked these questions: are there aspects of mother's quantitative and qualitative linguistic input that are associated with their children's language outcomes? Okay. And if so, what specific linguistic elements of mother's input predict better language skills? Okay, the measures were a questionnaire that she had developed and published before this study called the SPICE, a Scale of Parental Involvement and Self-Efficacy. It was a questionnaire of how parents perceive their own efficacy in working with their children and how involved they perceive themselves to be in their child's intervention. The Rennell Developmental Language Scales for receptive expressive language, and mother-child interactions, where the children were recorded doing free play and some specific storybooks. Okay, the maternal linguistic factors, the quantitative ones she coded were mean length of utterance by the mother, the number of words, and the number of different words. And the quality or the qualitative aspects were communication strategies, or what you'll see we'll call facilitative language techniques, that are higher and lower level. Here are some 4 techniques that are considered high-level facilitative language techniques. How a mother interacts with her child. One is parallel talk, expansion, recast, open-ended question. Parallel talk would be the child doing some sort of a play task and the mother sort of giving a dialogue about what the child's doing. Expansion, the parent is expanding on the child's speech or what they're saying about the activity. Recasting from, say, a statement into a question, starting a dialogue about it, and then open-ended question. In other words, asking a question where there's not just a one-word answer. And then there's lower-level techniques such as closed-ended question, linguistic mapping, which is basically a child maybe picking up a toy and the mom say, "Oh, car." Labeling, put a label on something, just imitating the child, directing the child, asking the child to do something, and just commenting on what the child is doing. Okay, so all mothers' and children's utterances were coded for quantitative input, and the mother's utterances were coded for qualitative input. There was high inter-rater reliability. And for the language techniques, the total number of each language technique was divided by the overall number of mother's linguistic attempts. Okay. There were 32 children in this study. You can see their age was a little over 4.5 at the time of enrollment. They had been a little over 2.5 at the time they were implanted. And most were identified early, although 3.4 years. California was in transition during this time of getting newborn hearing screening, so there were still children when she was collecting her data that were not, that missed the newborn hearing screening. Okay. So the children's language age, we know that the receptive age, they were about 2.5 years. So that's at the time of testing where they were around 4.5 years, so there was a two-year lag. Now, the correlations between maternal self-efficacy and involvement and the facilitative language techniques. There was no correlation or statistically significant correlation with the quantitative techniques or the MLU, mean length utterance, and different word types. But for the facilitative language techniques, the higher level technique of parallel talk was significantly related to the mother's sense of being very efficacious in working with her child. The lower level techniques, these 3 techniques was an inverse relationship. In other words, mothers who had high self-efficacy tended not to use these lower level techniques, and vice versa. Mothers who had low self-efficacy tended to use these lower level techniques with their children. Now, that was self-efficacy. What about maternal involvement? How did the mothers perceive themselves to be actively involved in their children's care and intervention? Again, Higher level techniques of parallel talk and expansion were significantly related to mothers feeling they were highly involved, whereas the inverse relationship for these 4 lower level techniques indicating that highly involved parents or mothers tended not to use lower level techniques, and vice versa. Parents who felt they were not actively or strongly involved with their children tended to use lower level techniques. Now, here are the correlations of child language and mother's quantitative linguistic input, the child's language on the Renell for receptive expressive, and we see that mother's mean length of utterance was correlated, statistically significantly correlated with both receptive expressive language, not with total number of words, but with total number of different words. And the correlation between child language and mother's qualitative linguistic input, these facilitative language techniques. For receptive language, the higher level technique of recasting from a statement to a sentence, was significantly related to the child's receptive language, and with expressive open-ended questions was statistically significant. How about lower level strategies? Again, they were all inverse relationships, and the techniques that came out in the analysis were linguistic mapping, labels, and directives. So stepwise multiple regression was performed, and the predictors of children's language abilities that came out were the child's age, the mother's mean length of utterance, the mother's use of recast for receptive language, and the mother's use of open-ended question for expressive language. So the summary of findings for this study is that mothers' perceived involvement and self-efficacy were related to the mother's linguistic input, the qualitative, not the quantitative. In turn, mother's linguistic input was related to the children's language abilities, and mother's use of open-ended questions and recast were positively related to children's language skills. Okay. Study 2, I'm not going to go into as much detail, but this is to investigate the language literacy connection and to investigate the child and maternal factors during the preschool years and how they contributed to later literacy skills. So the research question, the first one was, are there relationships between children's later literacy skills at time 2 of testing and their early language skills, which were acquired at test 1, and their current language skills, test 2? Second question, were children's later literacy skills at time 2 associated with their mother's early facilitative techniques during storybook reading? Remember, they were coded on play and storybook. This was just looking at the storybook mother-child interactions. The child factors were their language on the Renell at time 1, the oral written language skills at time 2, phonological awareness test at time 2, and the Woodcock-Johnson test, a reading test at time 2. And so for the maternal factors, the facilitative language techniques during storybook reading, they coded the same, again, those same questions, those same facilitative language techniques, the higher level and lower level. Only half of the children returned for that study. At time 1, they were almost 4.5, and at time 2, they were 3 years older when they were tested. Okay. These were their receptive language age. This isn't standard score, but age. At time 1 on the one test, time 2 on the other test. And you could see that there was some growth, not 3 years growth, but 2.5 years growth for receptive and expressive. So without giving you all the correlations, I'm just going to give you the results. Positive relationships between children's language skills at time 1 and time 2 and phonological awareness and reading scores were found. And at time 1, the expressive language was found to be correlated with phonologic awareness and reading skills. And time 2, both receptive and expressive language were related to phonologic awareness and reading scores. Children with an expressive standard score, before I was talking about language age, but at a standard score below 70 at time 1, also tended to perform below average, less than 85, on phonological awareness and total reading tasks at time 2. And mother's higher level language techniques at time 1 were related to children's later literacy skills, specifically open-ended questions and recast. So, after 30 years of working with children with hearing loss, I've finally come to understand it's really all about the mothers. So where are we going? What next? We're just at the early stage of the 21st century. And what might be coming? I mean, the technology is changing at such a rapid pace. You know, the things that I could come up with, and I'm sure there are people in this audience that have much more insight than I do, but hair cell regeneration, will that ever come to fruition? Research has been done on decades. I just don't know. Genetic engineering. You know, biotechnology, yeah, that may become a reality. And what about super duper cochlear implants? I think that's possible, restoring hearing close to normal. That may be in our future. But when I started this lecture, I talked about children with single channel implants. And that was the very beginning of this technology in children. And those children were born too early to benefit from later technology advances. The same thing will happen with any one of these technologies. And so we have a cycle. And when future developments become a reality, whether it's biotechnology or super duper cochlear implants, there will be human trials, first with adults and then with children. And as with the first pediatric cochlear implant trial 33 years ago, parents will be making difficult decisions for their children. And so the past is prologue, the cycle begins again. We've seen parents of children with early onset deafness ask, what should we do? Then they're faced with decisions about device technology. They pick one, and then we evaluate their communication and academic outcomes, and then new technology comes, and parents ask what to do. But for sure, those first children in those first trials may not do as well, but they will clearly contribute to our knowledge to the next level of technology. And that's my message. And I'd like to introduce you to my staff at House Research Institute. I direct the Pediatric Hearing Loss and Auditory Perception Lab. These are my staff members, and I'd like to highlight Arthur Boothroyd, who's a collaborator. I have special acknowledgement for Jean Desjardins and Sophie Ambrose, both doctoral students in my lab. And I, not now, they've gone on, but I have reported some of their findings in this oration. And John Naparko, who heads the CDA-CI study, and Nayu Wang, who is the biostatistician who helped develop the speech recognition index. And I'd like to also acknowledge funding on some of the studies I reported from our lab come from the National Institute on Deafness and Other Communication Disorders of the National Institutes of Health. And with that, I will conclude and thank you for your attention.